Hi everyone, my name's Katie Wiskar, and I'm here with a collaboration from UBC IM POCUS and Western Sono with a screencast covering the principles of Doppler ultrasound. Thanks to Rob Arnfield and Shane Rishenkoff for their help with this project. Now you may be wondering why it's worth it to understand the principles of Doppler physics. So Doppler is the language of blood flow and direction, and a basic understanding of Doppler principles really allows you to progress to the next level of POCUS. Once you understand the core principles, you can translate them to a whole host of other applications. So spectral Doppler is obviously key in advanced cardiac ultrasound, but it's also used in a wide range of other applications, like vascular ultrasound for carotid stenosis, hepatic and renal vein ultrasound for venous congestion, transcranial Doppler for ICP, and others. So a thorough understanding of spectral Doppler will really take you to the next level in your quest for POCUS mastery. Alright, so in this screencast, we'll briefly review the Doppler principle and go through some unavoidable physics. We'll touch on the different modes of Doppler, so the forms of spectral Doppler, which include pulse wave, continuous wave, and tissue Doppler imaging, as well as color flow Doppler. And then we'll go through a bunch of examples to really illustrate these various modes in action. So the Doppler principle. So this is probably familiar to most people from high school physics. However, like most things from high school physics, it's probably buried pretty deep under years of medical training. The classic example that you might remember is that of an ambulance siren changing in tone as it drives past you, and this is because of the changing frequency of the sound waves relative to you, a stationary observer. Now to apply this to ultrasound, the probe is going to be both our source of sound waves and our observer, and the moving part of the equation is the reflector, which for us is almost always blood cells, but occasionally tissue. And if our blood is moving towards the probe, then the reflected ultrasound waves are increased in frequency and we get a positive Doppler shift. Conversely, if blood is moving away from the probe, then the reflected ultrasound waves are decreased in frequency and we get a negative Doppler shift. Now these shifts can either be represented by a color map or by spectral tracings, as we'll see. So there are a few things that can affect the degree of Doppler shift. Higher frequency probes, like the linear probe, will generate greater Doppler shift. However, the selection of your probe is always going to be a balance between sensitivity to flow with high frequency probes versus penetration with lower frequency probes. The next thing that can affect your Doppler shift is the velocity of blood itself, with higher velocities of blood generating a greater Doppler shift. And finally, your angle of insonation. And this is really key from a POCUS perspective, and it helps us determine which views we want to use to interrogate a valve or blood vessels. We always want to align our view so that blood is flowing parallel to the angle of insonation. That is, blood is flowing either directly towards or away from our probe. Now, obviously this can be challenging and sometimes it's impossible to be totally parallel, but we'll do our best. And so here are a few things that we can do to try to optimize our angle of insonation. We can choose certain views, particularly in cardiac scanning, that allow for optimal orientation of our probe relative to the area of interest. We can employ probe manipulation with techniques like fanning or rocking the probe as we're in a given view to try to optimize our alignment. And we can make use of the angle correct function, which is present on most machines, which can correct for suboptimal alignment within reason, though this generally doesn't work beyond about 60 degrees. So here in this illustration, we can see how blood flow along a single vessel will be represented by different Doppler shifts as the vessel changes its course. Initially, you see that blood flow is predominantly towards the probe, which creates a positive Doppler shift. As the vessel moves more perpendicular to the probe, there is minimal Doppler shift. And finally, as blood flow is now away from the probe, we see a negative Doppler shift. Finally, one last bit of physics, the Bernoulli equation. So the Bernoulli principle, again, is probably familiar from high school physics, can be simplified to the equation below, and this allows us to use a measured velocity to calculate the pressure gradient between two chambers. And we'll see how this becomes important as we go through a few examples later on. Alright, so let's dive right into spectral Doppler. So spectral Doppler provides a graphical representation to plot the velocity of blood on the y-axis over time on the x-axis. And blood flow towards the probe is going to be represented by a positive deflection above the baseline, whereas blood flow away from the probe is going to be a negative deflection below the baseline. Spectral Doppler can be divided into two principal applications: pulsed wave Doppler, referred to as PW, and continuous wave Doppler, CW. Tissue Doppler imaging, or TDI, is a specialized form of pulse wave Doppler used for specific applications. Color Doppler is a separate form of Doppler, however, it functions on similar principles as pulse wave Doppler. Let's talk in a bit more depth about each of these various modes. So pulsed wave Doppler, or PW, functions by sending pulses of ultrasound waves to a specific location, then pausing before listening for reflected waves. This pause to listen is a key feature of PW, as we'll see. Continuous wave Doppler, or CW in contrast, functions by continuously sending ultrasound waves along a line while simultaneously continuously listening for reflected waves. Let's dissect in a bit more detail the difference between these two modes of spectral Doppler. As we mentioned before, the obligatory pause to listen is a key feature of pulsed wave Doppler. Because of this pause, PW is limited by what we call a pulse repetition frequency, or PRF. The PRF is defined as the cycle of emitting a sound wave into tissues and then pausing before receiving the returning echo. PRF is influenced by both the intrinsic characteristics of the ultrasound transducer as well as by the depth of the structures being interrogated. Intuitively, we can understand that it takes longer for ultrasound waves to travel to and from deeper structures compared to more superficial ones. The presence of the PRF leads to what we term the Nyquist limit, which is essentially the upper limit of blood velocity that can be detected using pulsed wave Doppler. And the Nyquist limit, by definition, is half of the PRF. And this is because in order for the transducer to be able to accurately interpret the reflected ultrasound waves, it must be able to sample a wave at least twice per wavelength. So this is most easily demonstrated graphically as we see here. In panels A and B, we can see that each wavelength is sampled at least twice, so these would be interpretable by PW. The blue wave, which is the true ultrasound wave, and the red wave, which is the machine interpretation, are aligned. And in contrast, in the bottom panel C and D, the wavelengths are sampled less than twice per wavelength. That is, the frequency of the wavelength is too high to allow them to be accurately interpreted by PW. So here the red wave, which is the machine interpretation, isn't accurate because the true ultrasound wave, in blue, isn't sampled frequently enough. The velocity of blood that generates these reflected sound waves therefore exceeded the Nyquist limit for these bottom panels. So here we have an example of a PW tracing where the blood velocity is within the Nyquist limit. We're able to trace and interpret this waveform, and it would correspond to panels A or B in the previous graphic. In contrast, we see now on screen right an example of the spectral Doppler tracing where the velocity of blood flow exceeds the Nyquist limit. What we get here is an ambiguous signal with no clear velocity waveform that is uninterpretable and can't be measured or quantified using PW. And this is called aliasing. As you can see, we have ambiguous signals both above and below the baseline, and the machine can't make sense of the waveforms. So this would correspond to panel C or D from our previous graphic. And the presence of the Nyquist limit is the primary limitation of pulse wave Doppler. A few other quick words about the Nyquist limit. So we can adjust the pulse repetition frequency and therefore the Nyquist limit to suit specific applications. If our target object or blood flow is slow moving, we can turn down the PRF to allow for longer listening time to catch these low flow signals. And conversely, for fast moving blood flow, we'll often maximize our PRF so that we can try to make use of PW's spatial resolution, but still resolve these higher frequencies. So in contrast to PW, with continuous wave Doppler, you're continuously sending a signal and receiving along that line of interrogation. So there's no obligatory pause to wait and listen for return signals. So CW is not limited by a PRF, and there's no Nyquist limit. So the advantage here is that you're able to measure much higher velocities. This is the sample view that we interrogated with PW on the right-hand side and was uninterpretable. And we can see that with CW, we can alter our scale as much as is needed in order to properly measure the velocity of blood. In summary then, the primary advantage of pulse wave Doppler is that we can measure blood velocities at a single precise location, the advantage of spatial precision. However, the downside here is that we're limited by a Nyquist limit, which is determined by the PRF and cannot interpret very high velocities. In contrast, the primary advantage of continuous wave Doppler is that we're able to accurately quantify very high velocities without being subject to a Nyquist limit. However, because we're continuously sending and receiving signals along a line of interrogation, we're not able to pinpoint exactly where the measured velocity occurs. In other words, we have spatial ambiguity. So typically in applications where we use CW, this spatial ambiguity isn't a problem, as there's really nothing else that would generate such a high velocity blood flow along the line of our signal. By convention, you'll see that the PW symbol is a small equals sign, whereas the CW symbol is a diamond shape. And you'll note that the diamond shape of CW is an area of focus, but its location is not particularly influential as long as the Doppler signal is strong. So you'll pick up velocities from along the entire line of interrogation. Moving on from PW and CW, a quick word about tissue Doppler imaging. So TDI is a form of pulse wave Doppler that has been optimized to measure movement of myocardium. So it maintains PW spatial precision, but is designed to capture high amplitude, low velocity signals, and we'll see an example of it later on. Finally, color flow Doppler, or more simply, color Doppler. So while not considered a kind of spectral Doppler, color Doppler does operate on the same principles as pulse wave Doppler. That is, it generates a color map by sending multiple signals to specific locations within the color box. So because of this spatial precision, it too is subject to a Nyquist limit, and again, velocities that exceed the Nyquist limit will be subject to aliasing. Now, unlike in spectral Doppler, where velocities are represented graphically, in color Doppler, as the name would suggest, we use a color map to represent blood flow. By convention, blood flow directed towards the ultrasound probe is shown in red, and blood flow directed away from the probe is in blue. Note that the color map will always be displayed on the ultrasound screen to reorient you if needed. So as we mentioned before, color Doppler is subject to aliasing, just like pulse wave Doppler. However, we often make use of aliasing in color Doppler to help us identify areas of very high velocity blood flow. In a color map, aliasing is represented by a mix of yellow, red, and blue colors. And it takes on all these colors due to the machine senselessly plotting directions of flow, as it is unable to resolve their direction, given that they exceed the Nyquist limit. So here we have two images of an apical 4-chamber view looking at blood flow through the mitral valve. On screen left, we have a normal mitral valve with that red mitral inflow, compared to on screen right, a stenotic mitral valve where there is that high velocity aliased flow. So just as we can adjust our PRF and Nyquist limit for pulse wave Doppler, we can do the same thing for color Doppler. Program presets will typically do this automatically depending on the flows in the relevant area, and we'll see why as we go through a few examples. And this is important to note, as you can get falsely absent color flows in an area if your Nyquist limit is set too high to interrogate your vessels of interest. Color gain can also be adjusted. Again, most presets will automatically set this at a reasonable level. And to test this, you increase your color gain until you see spontaneous color speckling, and then dial back just slightly from there. It's once again important to try to align the direction of blood flow to be parallel to the angle of interrogation of the probe. In addition, the color box should always be the right size, so we want it as small as possible while still encompassing the structures of interest. And always note that your color signal will be suboptimal if your image is generally of poor quality, if the structures being interrogated are very deep, or if you have a large angle of insonation, meaning that you're not very close to being parallel to the direction of blood flow. Alright, now we'll go through several examples to illustrate the uses of each type of Doppler. To qualitatively assess valvular regurgitant lesions, for example, we'll use color flow Doppler. Here, aortic regurgitation can be seen as a blue jet in this parasternal long axis view. Note that because the angle of the regurgitant jet is not parallel to the angle of insonation, in fact, you could argue that it's close to perpendicular, the degree of regurgitation may well be underestimated. We can also use color flow Doppler to help us with the identification of blood vessels, for example, helping us to find a small radial artery when inserting an arterial line. Here, we have an example where color Doppler helped highlight the presence of a blood clot in the right IJ, which would obviously be important to know prior to inserting a central line at this site. Here's another example where color Doppler has helped confirm the presence of blood vessels rather than a dilated renal pelvis in this echogenic kidney. Next, let's talk about how to assess for aortic stenosis. So in attempting to quantitatively assess aortic stenosis, we're looking at very high velocities as they pass through a narrowed aortic valve. So to do this, we need to use continuous wave Doppler to allow us to accurately interpret these high velocities. So here, we'll see the initial use of color flow Doppler to identify the aortic outflow tract. And then we have continuous wave Doppler to quantify the velocity and pressure gradient at the aortic valve. And again, the spatial ambiguity of continuous wave Doppler isn't a problem here because there's nothing else along this line of interrogation that would generate velocities anywhere near as fast as those leaving the aortic valve. And if you want more on how to use Doppler to distinguish aortic stenosis from aortic sclerosis, see the short screencast that's linked in the video description that's posted on the Western Sono page. All right, moving on to transcranial Doppler. So TCD is an emerging non-invasive way to monitor for intracranial pathology. Here we're going to use two methods, color Doppler initially to locate blood vessels, followed by pulse wave Doppler to measure velocities. And for more on how to actually do this, again, see the screencast on the Western Sono site, linked in the video description. So here we have the color Doppler, which allows us to locate the intracranial vessels, in this case, the middle cerebral artery, which is our target vessel. And note that since we're on the TCD preset here, our Nyquist limit is automatically been adjusted to detect lower velocity flows than we're used to in the heart. And next, we've used PW to generate a spectral waveform tracing, which we can measure and use in various calculations. As another example, let's look at using the tricuspid regurgitant jet to calculate right ventricular systolic pressure. We use this in the identification of pulmonary hypertension. Here, once again, we're dealing with high velocity blood flows, so we're going to use continuous wave Doppler. Initially, we use color Doppler to identify a regurgitant jet, seen here in a peristernal RV inflow view. Next, we'll use CW to obtain a waveform velocity tracing, which allows us to determine a maximal velocity and pressure gradient using the simplified Bernoulli equation. You may have noted that in these examples, really the only use of CW is in a cardiac context. This is because the heart is really the only place in the body where blood flow is fast enough to encounter issues with the Nyquist limit, and where we need the high velocity capabilities of CW. Almost everywhere else in the body, we use PW because we benefit from the spatial precision of PW without encountering issues with aliasing. To emphasize the importance of aligning the direction of blood flow with the angle of insonation of the ultrasound transducer, here we have a view from the same patient, once again using color Doppler to identify a TR jet. This time we're in a peristernal short axis view. And note that in this view, because the alignment of the regurgitant jet is optimized, the calculated maximal pressure gradient is substantially higher than the previous view. And this is particularly true for TR because the tricuspid valve is quite flimsy and can be challenging to identify the maximally regurgitant jet. So if you are attempting to measure RVSP, therefore, it's ideal to try multiple views in order to capture the one that really optimizes alignment. We also want to make sure that we make small probe movements, typically fanning, once we're in our view to make sure we're optimally capturing the jet. There's increasing interest in the analysis of Doppler waveforms from the hepatic, renal, and portal systems to inform various disease states such as fluid overload and venous congestion. And for the true ultra nerds who want to learn more about this, there's a few blog posts over at Think in Critical Care by Philippe Rolla that are a good starting point. And stay tuned for a screencast from Western Sono on the same topic. So for these techniques, we're going to first again use color Doppler initially, followed by pulse wave Doppler to analyze blood flow in specific locations. Here's the initial clip where we've used color Doppler to highlight blood flow in the hepatic vein. And now we've used PW to generate a velocity waveform tracing over the hepatic vein, which we can analyze and which shifts in various disease states. Here's one more example of PW used in this setting, this time interrogating the blood flow in a renal artery. And I'll just bring your attention to the fact that the Nyquist limit on our color Doppler and the scale for our PW tracing have both been turned way down, which allows us to accurately assess the relatively low blood velocity in this location. Next, let's look at the example of determining stroke volume using LVOT VT measurements. Again, for a full tutorial on stroke volume calculations, please see the screencast on the Western Sono site, which is linked in the video description. To calculate the VTI at the LVOT, we must use pulse wave Doppler because it's important that we're evaluating the blood flow specifically in the LVOT and not anywhere else along that line. And we calculate LVOT VTI in an apical 5-chamber view, so you can maybe therefore appreciate that if we use CW instead of PW and sampled blood volume from all points along that line of interrogation, that we would actually also be analyzing blood flow from beyond the aortic valve. And in all patients, even those without any aortic stenosis, blood flow after the aortic valve is always faster than blood flow before the valve, as the valve represents a natural narrowing of the orifice through which blood is passing. So therefore, the only way to be sure that we're measuring blood flow before the valve is to use PW for its spatial precision. So in this clip, we're seeing an example of a velocity waveform tracing taking in the LVOT in an apical 5-chamber view. The area under the curve, or VTI, is traced, which can be later used to calculate stroke volume and cardiac output. Finally, let's look at the example of diastology. So diastology is another hot topic in the POCUS world, and a full review of this and the merits of diastology in a point-of-care setting are definitely beyond the scope of this screencast. From a Doppler perspective, though, we're going to be using both pulsed wave Doppler as well as TDI, tissue Doppler imaging, for diastolic measurements. So to measure mitral inflows, we use pulse wave Doppler, as we want to look at the blood flowing out of the mitral valve at this specific location. And note that in the case of mitral stenosis, you may actually need to use CW to quantify blood flow at this location because of high velocities of flow. And obviously the presence of this kind of valvular disease is going to make these diastology measurements of limited value, but again, that's another talk for another time. Next, here we've employed tissue Doppler imaging, or TDI, to evaluate the movement of the lateral mitral valve annulus in this case. And again, this technique is very similar to PW, but gated for very low velocity such that we can accurately quantify the speed of the movement of the myocardium itself. Alright, so after all those examples, here are the take-home points. Doppler is a technique that uses changes in the frequency of reflected sound waves to tell us about the velocity and direction of blood flow. We have a few different modes of Doppler, as summarized here. PW is characterized by spatial precision, but is limited by a Nyquist limit and aliasing at high velocities. CW, in contrast, has spatial ambiguity, but is good at measuring very high velocities. Tissue Doppler imaging is like PW, but is specifically gated for very low velocities, like movement of the myocardium. And color Doppler gives us some visual directionality of blood flow and is also subject to a Nyquist limit and aliasing. All right, so thanks everyone for listening. That's all for today. Let us know if you have any questions, and happy scanning.